Next, it's my pleasure to introduce Saül Martinez. Saül works at the Movement Disorder Unit at St. Paul Hospital in Barcelona. He's a neuropsychologist, I guess it's fair to say, because you've always been interested in how the mind works. And he's got vast experience in Huntington's disease, but because he works at a movement disorder clinic, also vast experience in other movement disorders and neurocognitive disorders. So we are very much looking forward to you representing the Cognitive Phenotype Working Group. Thank you, Saül.
So, thanks, Michael. Thanks, Kristina. It's a pleasure to me to share with you, and on behalf of Jaime Kulisevsky and on behalf of all the members of the Cognitive Phenotype Working Group, the things we have been doing and all the ideas we want to move forward during the following next years. As said, this group is led by Professor Kulisevsky. He's not here today because of the MDS in Madrid, but tomorrow he will be here by myself and with the collaboration of Luz Lopez as Alanco. In terms of members, we are more or less active 45 members. It's not the same if I count those answering emails or those coming to our meetings, but anyway, there's a lot of people interested in cognition in Huntington's. But the thing is that almost all of us shares a very similar point of view on regards of the current state of the art around cognition in Huntington's disease and on the limitations. Let's say, for many people, much of what we know regarding cognition in Huntington's comes from research studies and raw data from research studies like Enroll Registry or other large cohort studies. And obviously, all of these studies has demonstrated to us fundamental questions concerning the usefulness of some cognitive variables to track disease progression and etc. But for sure, this is quite far from characterizing from a clinical neuropsychological perspective the cognitive phenotype of Huntington's. Clinical neuropsychology of Huntington's is much more complex and variable than what these studies can tell us per se. And it's surprisingly how in Huntington's, but not in other neurodegenerative diseases where cognitive impairment occurs, we still do not have a consensus regarding the different neuropsychological syndromes or pathological cognitive states occurring, or the idea of Huntington's as a subcortical dementia and that's all, which is certainly outdated and far from clinical reality. We do not have either brief assessment instruments specifically validated for this disease or recommendations on the comprehensive neuropsychological assessment protocols to better characterize our patients. And around this limitation is what we were working and want to work and achieve some objectives. And let's make clear that we are talking about clinical neuropsychology. We are not dealing about cognitive things in the context of more basic research. It's evident that cognitive changes are not necessarily equivalent between neurodegenerative diseases and cognitive assessment instruments and generalistic diagnostic approaches that may work in one disease, for instance, Alzheimer's, may not work in another, for instance, Huntington's or FTD or Parkinson's. To solve or at least to explore all these things, we conducted in a multi-center manner on behalf of the Cognitive Phenotype Working Group a study to test to see how useful may be an instrument we previously developed at our site to address cognition in Parkinson's and to see if it works maybe better than other instruments of global cognitive assessment in Huntington's disease and demonstrated that at least with some limitations is useful. This is a good achievement from the working group that helped also us to explore the kind of brain changes occurring in HD patients sharing same age, education, CAG repeats, but exhibiting a dissimilar pattern of cognitive progression. In this multi-center study, we incorporated a series of brief subtests with intention of exploring if it may be useful to include these tests in the cognitive protocols for Huntington's. We have data from 183 participants and a set of controls with the main core assessments from Enroll-HD study and all this set of cognitive variables, emphasizing on mental rotation, arithmetic, visual working memory, planning, and verbal inhibition. Thanks to this, right now, we recently published this work showing that word problem arithmetic solving is already detectable in terms of some deficits in pre-manifest individuals as a function of the complexity of the tasks you are facing these people with. Of course, all the remaining data must be analyzed, and we are open to any kind of idea or to people who wants to interrogate this data according to specific scientific questions. We have in preparation another work just looking at how all these cognitive variables changes along 1 year, but specifically in those people exhibiting a more aggressive pattern of cognitive decline in 1 year. And as future but immediate lines of research, we want to do things, of course, with the enrolled-HD data. We want to better understand not what the raw data is telling to us. We want to understand what happens if we standardize this data using normative data from each country. We also want to see which is the history telling to us all of those variables related to efficiency during cognitive performance, such as the type of errors, perseverations, intrusions, self-corrections, clustering effects, etc. And probably the most ambiguous project and the main topic during our meeting yesterday is the elaboration of an expert-based clinical guideline for neuropsychological assessment in Huntington's disease. It is, if a person more or less expert in Huntington's here or in China faces with a patient, the kind of recommendation in terms of which cognitive screening instruments to be used, with what kind of cutoff scores to be used, the kind of recommended exhaustive neuropsychological tests to be included, or how to deal with things like ability to drive, decide, work, among many other aspects. We also initiated a contact with the neuropsychology working group from the Huntington's study group, and we will see if we can work together or do something together based on the ideas or the objectives we share. And as always, we're open to any kind of ideas where this cognitive phenotype working group can lend logical or practical support or any other type of support, so everybody is super welcome to ask us things or to come with us. These are our contacts, and thank you very much.
Thank you very much, Saül. I'm sure you welcome questions. I can't see any hands. Blinded. Blinded. So everything is very clear. Can I ask you a question?
Sure.
If you had a wish, what would you wish for? The echo is terrible. If you had a wish, what would you wish for your working group to be successful quickly?
Quick. You have a wish.
Yeah.
To be successful quick.
Yeah.
Well, at least to provide the community with this guideline, I think is something really necessary in the field. Everybody from other neurodegenerative diseases have this kind of guidelines, and I'm pretty sure that many people doesn't know how to deal with neuropsychology in a clinical setting in Huntington's. So,
do you need any help putting the guidelines together?
We need people.
People. What sort of people would you need?
I think we need this kind of experts. The idea is not to run this just from people who attended our meeting. The idea, after defining the main points that will appear in this guideline, the idea is to interrogate the whole community using surveys, and we need the insights from everybody working in the field to understand from their point of view and to put it together with our point of view and make something practical. We want to be practical. In absence of diagnostic criteria for something like MCI or for something like dementia in Huntington's, we want to be practical. How to do it, what kind of names we can use in this context when we refer to cognitive impairment in our patients.
So in essence, once you've put some guidelines together, you'd like a sounding board, so some people to have a look at it.
Of course.
And see whether they think it works.
Sure.
Okay, so we put a call out for you. Okay.
There's a question.
Thank you so much for this contribution. I think you will strongly agree that cognitive decline should be included in the diagnostic criteria to call it a manifest disease and not a pre-manifest disease.
Yeah, sure. I think, but this is another topic we can discuss. But for sure, everybody working with Huntington's knows that years before the obvious presentation of these things defining the diagnosis of Huntington's, many cognitive things may occur. Also, many behavioral things may occur. What I'm pretty sure is that we need to go more deeper in the several cognitive phenotypes occurring in this disease. What, from the opinion of neuropsychologists, is a bit ridiculous, is that in other common neurodegenerative diseases, they know almost 4, 5, 6 different cognitive phenotypes, and seems that for Huntington's, there's the cognitive phenotype of Huntington's, and the clinical reality is much more different than this idea.
Thank you, Saül. So next we will hear from the lead facilitators of the physiotherapy working group. Una Jones, who's a reader at School of Healthcare Sciences at Cardiff University, and Anne Clues and Deb Kegelmeyer, who are both professors of health and rehabilitation sciences at the Ohio State University. They will be speaking about how the physiotherapy working group works to influence physiotherapy clinical practice to ensure an internationally consistent approach for people with HD. Welcome.